Yes?
Can you hear me? Sorry to interrupt, Jason here. What if when you've taken the hump off, you've got an open vault there?
If you have an open vault, then I do something differently, where I can no longer, the open vault's open. So what I'll do is I'll separate the upper lateral cartilages so I can see that dorsum, the new dorsum of the septum, and I'll actually sew in the cartilage, because then you have to sew it in, because otherwise it'll pop through and it won't be in place. So what I'll do is I'll take a big 4-0 nylon and I'll put it through the upper lateral cartilage, and then I'll take that 4-0 nylon and use it as a retractor, and I'll retract out that upper lateral cartilage to the drape, so that way it's spread out so I can see in there real well. And then I'll put in the spreader graft and I'll sew it in with the 5-0 PDS under direct vision. I think I have a picture of that. I'll show it to you here in a second, because that's a really good question, because that does happen. Sometimes that middle vault is, if you have a big hump and you take it down, then it's wide open roof, and you can't just put it into a precise pocket. So then you have to place it in, they have to sew it in directly with the 5-0 PDS. If I have a caudal septal deflection like this, oftentimes I'll cut out that caudal septal deflection, and then I'll replace it with the caudal septal extension graft. I may just turn it around and suture it into place just like this. So this is turning it around and suturing it into place in the opposite direction, and I use 4-0 PDS for this, and under direct vision I suture it in to what's the caudal septum, and then I'll often do a tongue and groove on that. So just like that, I'll take that cartilage and I'll suture it to the most caudal portion of the septum. And here's it showing that right here. So this is the septum, and I suture it just like that, the 4-0 PDS, put it in place, and now you can see the new caudal septum. So my nostrils retracted, there's the caudal septum. I'll make a tiny pocket between the medial crow's foot plates, so the medial crow's foot plates can now fit on to that new caudal septum after it's already been placed. I like doing caudal septal extension grafts. I'm doing a lot of it now. And my tip is straighter, right on the table. And this is one of the benefits of a closed approach, is right on the table you can see that your tip is straighter. Through an open approach, sometimes you don't know. You put the skin soft tissue envelope back down, you're not 100% certain that it's straight. There's so much swelling. With the closed approach, you can see what you get right away. Tip is straighter. But once I do that, I do a tongue and groove maneuver. So as I was showing here, I make that pocket right between the medial crow's foot plates, and then I fit that pocket right onto the end of there. And I secure it in place, first with a 4-0 fast absorbing chromic, and then I may use a 5-0 PDS afterwards. But I get it in place with a 4-0 chromic, straight needle, Keith needle. So now I have the position of the tip set. And here's right on the table. So you can see that here was the tip, then I position it into place onto that new caudal septal extension graft, and now my tip is set. Now the 4-0 chromic, as you know, doesn't last very long, although I've been pretty impressed in some patients where I think it's pretty permanent. At least the scarring takes place enough time to keep that tip into position. But I take that extra measure and I'll use a 5-0 PDS or a 4-0 PDS to make sure that tip stays in place. So here's someone who I treated. This is about 8 months later, and you can see the tip is in better position after that caudal septal extension graft. She looks straighter. Someone else, and I did that same exact procedure. Tip is more projected. Here's the medial crow's foot plates. You can see here the medial crow's foot plates are way down here, but I've raised them after doing that caudal septal extension graft and doing a tongue and groove maneuver. Here she is also. Tip is more projected and more rotated, but that tip is set into position by doing a caudal septal extension graft and a tongue and groove maneuver. This is a young lady who I treated. This is post-op, and I thought she looked pretty good, but you can tell from this picture she's not happy, and she's complaining to me, "Doctor, you did nothing. I'm not happy. I don't look good. I'm getting married. You didn't do a good job. What can you do for me?" So she wanted her tip more rotated and she wanted more projection. I said, I don't really think you need it. She goes, that's what I really want. I said, okay. So I did that. I did a tongue and groove maneuver in the office. So in the office, I put a little local anesthetic in there, made a little pocket between the medial plates, and secured the tip onto the septum, the caudal septum. And now she's happy afterwards. Laterally, you can see this. This is pre-op, this is post-op. This is after doing what makes her happy, which is rotating and increasing projection of the nose. Now she's thrilled, but that's what she wanted. So that was done in the office, a little pocket between the medial plates, secured onto the caudal septum, the photochromic suture. Same thing with this patient.
Coach Jason again. You mentioned putting in that 40 PDS, the longer lasting suture. Is that tied on the outside of the mucosa, or are you doing that submucosally?
Submucosally.
Yeah. So I tried putting it on the outside of the mucosa a couple of times because I do that with the poro gut. I found that the poro PDS stayed there for months, and they came back and they loved the shape of their nose, but they hated the prickle that was up there and the thing that they could feel and drove them mad. I was just wondering whether you did that, but obviously you're doing it the right way. Thanks.
I'll try to do submucosally, but I have done it, you know, extracutaneously, and I'll cut it out months later because it starts to irritate them. I used to do it with a permanent suture because I thought you had to use a permanent suture. So I used to do this type of maneuver with a Proline, but I found I don't need a Proline anymore. Just using a PDS works for me, but in the past I did a Proline and then I would cut it out months later when it started to bother them. I didn't tell them the Proline was in there, but they come back 4 or 5 months later and they say, hey, I got something in my nose, it's bothering me, maybe it's bleeding or itching or causing obstruction. And then I cut it out, remove it. But I don't do that anymore. Now I use PDS and it works just as well. Same thing, increasing projection with a tongue and groove maneuver onto a caudal septal extension graft. You can see that here also. Another patient, same thing. Crooked nose, tongue closed, crooked nose, wide middle vault, narrowing of the middle vault, narrowing of the tip, caudal septal extension graft to set the tip's placement and a better result. Same thing here. You can see I excised her original caudal septum, turned it around, secured in place with the 40 PDS suture, and then secured the medial foot plates to the caudal septum, and it's in good position.